the functional or the stress testing. A very, very important component for assessment of cardiac pathology. And it can be done in different forms. We'll see that. So let's see. First, understand the principle. Okay, let's understand the principle. On what principle are we doing this functional stress testing? What are different forms by which stress can be given to induce ischemia? So basically, functional stress testing can be used in patients with stable ischemic disease, and it detects inducible ischemia. So it is basically detecting the inducible ischemia. So what's the principle is, we will give stress in the form of either exercise or a pharmacological stress to the patient. And once you give stress, this stress is going to increase the cardiac workload. This is going to increase the myocardial oxygen demand, and then we can detect the myocardial oxygen demand increases. In case ischemia is present, this inducible ischemia can be detected by these functional or the stress testing. Okay, so that's the principle behind using functional stress testing. Now, the stress can be given in the form of telling the patient to exercise, or it may be a pharmacological stress. Now, out of these, which is better, which one should be given? Out of this, for patients, especially who are capable of performing routine activities, they should be given a stress in the form of exercise. They should be subjected to exercise-induced stress. Why? Because exercise gives more physiological stress as compared to pharmacological stress. And secondly, it's a better way of detecting, ischemia. And plus, it also allows a correlation, the daily symptom burden and the physical work capacity of the patient. Okay. When do you go for pharmacological stress? Patients who are not capable of moderate or routine physical activity, who have comorbid conditions, in those patients will go for pharmacological stress. Okay, so these we have functional stress tests where we can have exercise-induced stress or a pharmacological stress, and I've told you that which one to be used in which set of patients. Okay, now if we talk about these functional stress testing, the first one, the simplest one, can be an exercise stress ECG. It's exercise stress ECG, where patient undergoes 5 3-minute bouts of treadmill exercise, and the response is measured as a maximum percentage of the heart rate achieved. The response is measured as a maximum percentage of the heart rate achieved, and a person is said to have ischemia, or ischemia can be detected in case there is 1 millimeter horizontal downsloping ST segment depression at peak of exercise. So, patient exercising, we are recording the ECG along with that, and ischemia would be detected, or ischemia would be documented if there is 1 millimeter horizontal or downsloping ST segment depression at the peak of exercise. But important thing is that a negative test, that means there's no what is called as ST segment depression, does not completely rule out IHT. It does not completely rule out the presence of ischemic heart disease. So, one form of stress test is your exercise stress ECG. Then other important form of stress test, as I told you, is stress echo. Very, very important form of stress test is stress echo, where we are looking for the regional wall motion abnormalities and changes in the global left ventricular function during stress and immediately after stress. And same story, the stress can be given in the form of exercise or in the form of drugs. That's a pharmacological stress. What drugs which we can use? We can go for dobutamine, or we can go for vasodilators like dipyridamole and adenosine. So these are the drugs which you can use for inducing stress. What is the endpoint? Endpoint is a regional wall motion abnormality after giving stress. So regional wall motion abnormality after giving stress, that's the endpoint for the stress echo. Plus, this stress echo can also help in detecting viable myocardium, the scarred myocardium, and impaired but recoverable myocardium. So, a viable myocardium, a scarred myocardium, and impaired but recoverable myocardium. Now, what do you mean by impaired but recoverable myocardium is, the myocardium which is impaired but recoverable will be recruited. It will be recruited into the function, while the scarred myocardium will not be recruited, because this impaired but recoverable has a functional reserve, so it will be recruited into function, while a scarred myocardium will not be recruited at all. So that's how it can differentiate a viable, scarred, and a what is called an impaired but recoverable myocardium. And this impaired but recoverable myocardium, there's something which are the patients who are candidates for revascularization.